Hey there, I'm Gilad Barash, and welcome to Who's Your Data, the podcast that deals with how data influences life and how life influences data, the human side of data analytics. Hey everyone, welcome to the Who's Your Data podcast. We hear many stories about how AI has become increasingly responsible for spreading misinformation, whether in politics, health information, or otherwise. But did you know that AI can be used to combat misinformation too? In this episode, we chat with Amelia Garcia, director at the Center for Health Communication Science at NORC at the University of Chicago, and Rebecca Soskin-Hicks, a pediatrician and fellow at NORC. We discussed their new initiative to create health communication using AI. Their thesis is that AI can be the next form of opinion leader, like social media influencers have been so far. We discussed the theory behind this thesis, how this AI model gets trained and interacts with humans, what the ethical concerns are. As a clinician, Rebecca also discusses the barriers to entry for using an AI in her practice, and we talk about the future of the study and share some contemporary tips for identifying health misinformation online. Let's get to the interview. Rebecca, welcome to the Who's Your Data podcast, and Amelia, welcome back to the Who's Your Data podcast. You have the honor of being my first guest that is returning.
Well, I'm happy to be back, Gilad, and thank you so much for having me and my collaborator and friend, Rebecca, here today to talk to you about some of the new work we're doing.
So about that work, nowadays when you hear about AI as it pertains to misinformation and information, it really does have more of a negative setting. But your work is about combating health misinformation with AI. So can we sort of just set the table and understand the landscape? Can you describe a little bit about the current challenges in health communication, particularly in relation to misinformation in the digital divide, and whether or not the rise of AI and large language models in particular today exacerbate these issues?
Yeah, so I think I'll speak to that first. One of the main challenges in health communication today is that most people seek health information online. Sometimes they seek it online first, and sometimes they're seeking health information only online. We know that there are about 70,000 Google health searches per minute, and 3 times as many people search for health information online every day versus people searching for health information with an actual healthcare provider. And 9 out of 10 adults are using social media, and over 60% of those adults using social media have researched health information on social media. Half of those who are using social media to find health information have said that they have not talked to a healthcare provider about the information that they searched and that they haven't checked the credentials of who posted that information. So just super important to acknowledge that most people are seeking their health information online, and that is part of why health communication is so challenging today. When we think about misinformation in particular, it is one of the biggest challenges that health communicators face. But I think it's important to acknowledge that just even using the word misinformation can be tricky at times, that it's hard to delineate sometimes what is good information and what is misinformation. Even for healthcare professionals, that's sometimes a hard thing to do, and especially in areas where the evidence is evolving or where consensus does not exist. So a little bit of data on that. The Kaiser Family Foundation survey last year found that more than 40% of adults have been exposed to online health misinformation, and that of those who've been exposed to online health misinformation, 50% of them weren't sure what to believe. They didn't know whether the information was true or not true. So when we talk about this, I also like to mention that it's really important that we understand that the vast majority of people who are searching for health information online have very good intentions. They're looking for the truth. They want answers to their health questions, and they're trying to make smart decisions for themselves and for their families. But they often run into this misinformation, or they often run into inaccurate information that they can't tell is inaccurate. And as a clinician, I saw this really drastically increase over the last few years with some concerning examples, things that happened in my clinical practice that I was really sort of brought me to have this concern. And one of the examples is a patient that I have been taking care of for several years since he was born. So I'm a pediatrician, so I take care of children, but I'm interacting, with their parents as well. And so I have a family who came in during the COVID pandemic, really afraid, really unsure what to believe, not sure what decisions to make about vaccination, not sure what decisions to make about exposures and masks and these types of things. And the mom told me that she was prepared to and had purchased all the equipment that she needed to nebulize hydrogen peroxide for herself and for her family, including for her young child if they got COVID. So that was a really disturbing and hard conversation to have, because this is a family that I know well, that has trusted me in the past. When my first reaction was, oh, please don't do that. That could be very dangerous for your lungs or for your child's lungs. There's really no evidence that that's effective whatsoever, and it's certainly not safe. It was a challenging interaction because she had read information that she thought was credible, and she felt that I was not informed or up to date on that information. So that's just one example, and there have been many, many others where health misinformation that people are viewing online is really impacting their health decisions.
Thank you. I was just going to add, you mentioned digital divide, and I think before we sort of talk a little bit about digital divide, I think it's important to note sort of the reason why there's so much misinformation online and in social media. It's sort of twofold. First and foremost, Rebecca mentioned this just now. There is so much information online, and there is so much information and news and data coming at people every single day. And so people have to find a way to make sense of all of that and how to sift through and figure out what to listen to, what not to listen to. And so as humans, we use heuristics, right? We use shortcuts to be able to sort of make sense of everything that we're kind of inundated with. And those shortcuts can be things like we listen to people that we know. We trust information that comes from people we know more than from somebody we don't know. We choose to read or listen to or find information and sort of believe information that supports our pre-existing beliefs because it makes sense to us and it's easier than reading something that might confront or differ from what we already believe and adhere to. But the problem is that these heuristics, these shortcuts, they actually really result in us sort of not necessarily always being seeing the full picture of what information is out there, because it limits what we have access to or what we choose to have access to. It creates echo chambers, and it's much harder then to introduce new information into those networks. And social media just amplifies all of these things, right? So social media rewards content that has high engagement. And so thinking, perhaps rightly so, that information that is highly engaged with is quality content. It's content that people like because a lot of people have engaged with it. That doesn't necessarily mean, though, that it's factual, right? That it is well documented in the literature that the highest engaged content is oftentimes like the funniest content or the most sensational content. It's not necessarily always truthful content. It really ends up amplifying all of the things that we do naturally as humans, because it's trying to give us more of what we like and less of what we don't like. And so further amplifying those echo chambers and the content that might not be the best content for us to consume in the first place relative to our health. The one thing I want to note in terms of digital divide is that a lot of this is happening online and in social media, and yet the discussion around digital divide is not as simple as, do you have access to internet or do you not have access to internet? It's actually well documented. Pew Research Center has been tracking broadband access and penetration for decades now. And in fact, broadband access has a good penetration here in the US, and it's improving in those areas that tend to be more rural areas. There is movement to sort of bring broadband to sort of those last mile areas. And in fact, for certain communities where you'd think that being online is a real challenge, and I'll just give one example, which is people experiencing homelessness. Oftentimes, smartphones and digital devices are a lifeline for those communities. It really is not always about access to devices or access to internet. What it does come down to is what people are comfortable doing in those environments. And so while people might be very comfortable texting or watching a video or listening to music, being able to integrate with systems online around health information, especially if they are sort of out of date or wonky or heavy or clunky, those systems can make it very hard for people to easily interact with health information in a way that actually benefits them and doesn't cause frustration and where they shut down and leave and then don't pursue that information further. So I think it's important when we talk about misinformation, health, and the digital divide that we're kind of thinking about this broadly, that it's not just access, but it's actually user experience as well.
And I wonder also if you can say anything about, in recent years, especially with the rise of AI and large language models, it seems to me that AI can contribute to the spread of misinformation in general and health misinformation in particular, in terms of certainly volume of misinformation, the automation of articles and posts that are written by large language models, amplification of these, like you said, things that have more engagement. Have you found that there is any more reason for concern or a rise in that kind of misinformation, especially since, they're training off of perhaps unknown sources? And so has that been something that you've looked at?
To speak to that, to what extent AI is generating false health information is not really well measured. So it's happening. Some of it is happening, but very challenging to measure it. There is more good data looking at the generation of false information by large language models in the political space and in the election space, less good measurement in the health space so far. So what we do have is evidence that it's totally possible. Last year, a paper was published showing that a few healthcare professionals using a large language model could generate 100 fake blog articles full of vaccine misinformation in less than an hour.
Exactly.
So this was just a handful of doctors, and in less than an hour, they created a ton of vaccine misinformation content on a commercial large language model. And then just a couple of months ago, another study evaluated several of these commercial and open source language models and found that they could generate disinformation about sunscreen causing cancer and about alkaline diets curing cancer. So we know that it's totally possible, and people are publishing research to show that. But to what extent it's actually happening in digital spaces where large language models or other AI tools are producing health misinformation, we don't have a good handle on that. The way that AI contributes to health misinformation, both hypothetically and realistically, is that they can very quickly create misinformation that looks accurate, that looks authoritative, and then they can really swiftly and really broadly disseminate that misinformation in a way that was not possible before. And sometimes this is going to be intentionally inaccurate, where you have true bad actors spreading disinformation. But most of the time, it's going to be accidentally inaccurate. So errors on the language model's part, or hallucinations, or maybe it fabricates sources and it's just giving bad advice. And so a good example recently is the Google Gemini sort of blunders. So after Google's big I/O event 3 weeks ago, they introduced, I think they call it AI Overview as a product in Google search. And it's just at the top of the page, and it uses one of their large language models to create an AI overview for you of what it thinks the answer is to what you're looking for. And so when that happened, people are going to sort of try to jailbreak it and test it to its limits. And many examples were sort of flooded on social media of this Google AI overview presenting inaccurate information, sometimes like laughably inaccurate, things like putting glue on pizza to make the cheese stick, and then sometimes potentially very harmful inaccuracies. Like one of them recommended that it said doctors recommend that pregnant people smoke 1 to 3 cigarettes per day. So these large commercial LLMs, they have guardrails in place. They have, I think, robust policies around this, but still this happened to a company like Google. And you can imagine that for an open source model or an uncensored model, the possibilities are much greater for producing misinformation.
And I think it also goes to show how difficult it is to put those guardrails around it. But at least in that case, they were talking about non-toxic glue in the pizza. So, I mean, maybe you knew what it was talking about. I don't know. But that said, okay, so we know that, AI can certainly help spread misinformation. How can AI be part of the solution to health misinformation? And what does it mean? What exactly is health communication AI? Can you talk a little bit about that, how it relates to social media and influencers? How effective is it in delivering accurate and empathetic health information?
Yeah, so Gilad, it's a great question, and we're really excited because Rebecca and we just have a paper out on this topic this week, and it really outlines kind of the vision for this. When we first started working together, Rebecca and I kind of came from two different perspectives, right? So she's a clinician who has been working in the tech space, and I am a health communicator who's worked in this sort of digital and social media and behavior change space. And a lot of my work built upon the foundation of the opinion leadership literature. The concept of opinion leaders first appears in Rogers' theory of diffusion of innovations. It was that work that really looked at how opinion leaders can help introduce and share and drive adoption of new ideas, innovations throughout a social network. And they can do that quickly, right? So they can kind of leapfrog over processes through which innovations would normally kind of diffuse within a social network. And in the health promotion programming space, the role of opinion leaders has been well studied, and there's a long history showing just how persuasive and powerful they can be to the diffusion and adoption of health behaviors within communities. My most recent work has really built upon that by looking at social media influencers as opinion leaders of the digital age. So as think about opinion leadership, and then we consider the advent of digital and social media, those opinion leaders have moved online. And so in prior work, where opinion leaders would be from the physical communities that health promotion programmers were working with, those communities now don't have the limitations of time and space. Those communities can be made up of anybody, anywhere, at any time, but they're coalescing around sort of a common interest or topic or initiative, right? So it could be that you are a dachshund lover, or you love knitting, or you're a foodie, whatever it is. Those communities have really kind of shifted and grown, and now they're just proliferated all over social media. And social media influencers have the same kinds of qualities that traditional opinion leaders have with their own communities. And so what that means is that they have credibility, that they're like them, that they're from those communities, that there's emotional connection between those opinion leaders and their communities. And in my own work, we've studied this in terms of a number of health topics, but in particular, most recently, we've looked at it in terms of vaccine hesitancy. And what we've shown is that exposure to social media influencers' messaging around both the COVID-19 vaccine and the HPV vaccine did drive statistically significant increases in awareness of the vaccine, knowledge that the health issues that the vaccine aims to protect people against are serious, intent and intention to vaccinate. And so I think what we're seeing here is how powerful these social media influencers can be as messengers of credible and evidence-based health information to drive behavior change. As I got to know Rebecca's work better, I started to sort of think about how do these pieces kind of all fit together, right? Because we are now in a new age of digital, right? With the advent of AI and the evolution of that technology itself, where it can be putting out different types of messages than what we've previously seen with AI technology. And so Rebecca and I have come up with this idea of health communication AI, which really blends what we know from the literature and from theory around the strengths and the opportunities within the opinion leadership space, and specifically recent advances in terms of social media influencers and what we know their influence on health information dissemination and behavior change with these new advances with AI technology. And we think that there's an opportunity to look at AI, and specifically health communication AI, in the way that Rebecca and I have envisioned, and I know we'll get into that in a little bit, that it can be the next form of opinion leader. So as technology and digital are evolving, it's not just going to end with social media influencers. We're going to start to see these same kinds of interactions between humans and AI that we've seen in the past.
So can you give us a little bit of a high-level view of what this architecture would look like, and kind of how the AI works in this case and disseminates that information? Specifically, I wonder about what data would be used to train the models and how the public would interact with them. And, would you include things like Facebook groups or user forums that could have misinformation in them? Just like, by the way, the example that you gave with Google Overview, that apparently the information about making the cheese stick to the pizza with glue came from Reddit forums and apparently The Onion. How does all that work?
Having authoritative sources for health information it's
That's a good start.
Strategy number one. Yes.
Yep.
Ultimately, our vision of health communication AI that we're developing through NORC is to build an integrated AI system that integrates social listening, sentiment analysis, and a chatbot to find messages and conversations on social media that could really use an accurate, informative point of view. But it all has to start with the development of the chatbot first. And as you likely know, that's really all about the data. We are instruction fine-tuning a generalized large language model using annotated data sets on specific health topics. These data sets are created by subject matter experts, and we're using data collection from high quality authoritative sources. So that's super important where you're getting your information from to create this annotated data. But we're also using, as you mentioned, data that is not from authoritative sources, and it has to represent and be annotated to show that it's misinformation, and then have it presented in various styles and narratives that are representative of common myths and misconceptions about that specific health topic. So that sort of data could come, as you said, from social media groups. It could come from online user forums. And in fact, those are a really important part of the training data because we have to explicitly show the large language model what is good information and what is bad information about this health topic. So the closer that this data set is to real life conversations and real life queries and real life messages, the better the model is going to be after instruction fine tuning, because you could just take a 10 question FAQ or PDF on the most common myths about a health topic, and you could maybe cover all of the myths, that are really common about that health topic. But that FAQ is not the way that users ask those types of questions. They use varied language, but there's a lot of nuance there. So the training data set actually has to be quite large. So that's about the specific health topics. And then we're also fine tuning on some general health topics like vaccine hesitancy, general information, and also health communication best practices. So the chatbot design also includes a good deal of prompt engineering. So we're going to be using in-sequence or parallel large language models as tools to act as things like a stage analyzer. So we have to analyze the theme, the sentiment of the message that the user has put in. We have to be able to look in that message and see if there's bias. And then we're also using parallel LLMs to implement guardrails, using prompt engineering to implement these guardrails so that we can prevent our chatbot from producing inaccuracies, so that we can ensure that empathy is conveyed in each of our messages, because that's a really big part of building trust, is using empathy in your message. And it's one of the main problems with standard health communications today is that they're often not empathetic. They often don't meet the user where they're at. And so we'll ensure those guardrails are there, mostly through prompt engineering, and then also for preventing the generation of bias through mostly prompt engineering. And so then this chatbot is going to be tested in many studies with various designs, including randomized controlled trials. So we want to be informed on our chatbot's ability to maintain accuracy, maintain empathy in real user interactions. And most importantly, we want to study these interactions and determine how they affect the user's knowledge and attitudes and beliefs and even behaviors about the health topics that they chatted about with our chatbot. So additionally, in each of our studies, we're going to use logging functions to store these conversations so that we can analyze them and do further analysis on accuracy, on empathy, and other categorical metrics. And so only after we've really thoroughly tested and proven that the chatbot is safe to use with real interactions with real users, only after that would we deploy a chatbot into this integrated AI system that we're designing to seek out those conversations and provide original engagement in social media spaces.
Are you training an LLM for specific health topics? Is there a finite set of health topics that this bot is going to be trained for, or is it more general?
Yeah, I mean, it's an ongoing process. So you have to start with a few health topics. You can't do it all at once. And so, for example, we have external partners that we're going to partner with to do some of these studies, and they're interested in a specific health topic being studied. And so in these initial randomized controlled trials and other study designs that we have planned, the chatbot will be chatting just about specific health topics.
Out of curiosity, I'm wondering if the phenomenon of health misinformation skyrocketed during the COVID era, and are you focusing on data from that era? I'm just curious because I know that, in today's fast-paced development of everything from technology to science, are COVID era findings obsolete already, or are there findings that you are still utilizing in this research?
Yeah, that's a great question. So in my consulting that I've done for the last handful of years for tech companies, I've worked heavily on COVID-19 health information. And I felt firsthand this skyrocketing and this massive amount of effort that technology companies needed to pour into handling COVID-19 information, both factual and misinformation. And so I also felt that very much in my clinical practice. We will fine tune on COVID-19 disease and vaccine information. We are definitely going to do that. But like any topic that has evolving evidence or maybe has areas where there's not robust international consensus, we have to take great care to include multiple perspectives while still acknowledging the strength or weaknesses of the data. So not every source is as reputable as others, and we have a system for ranking authoritativeness of health sources and for ranking accuracy of information. So absolutely, we're going to use COVID era findings. They're definitely not obsolete, but the tactics of some of the health messaging that was used in that era should probably be obsolete. And that's one of the things we're working on.
And Gilad, I'll just add that, in fact, at NORC, we've been working, and this is sort of an adjacent project. We've been working to develop a model of COVID-19 vaccine misinformation. It will actually be available a little bit later this year. But the model was developed based on, with COVID-19 vaccine information, because the historical record was so great. There was a sort of a clear moment when it started, and then we put sort of an endpoint on it. And it's so vast, right? There was so much discussion in social media around the emergence of the COVID-19 vaccine. It proved to be a great data set for training. And the idea is that this model could then be trained on other things, but that's kind of what we started with. So to your question and Rebecca's point, not obsolete. I think it definitely, COVID-19 data offers a lot of opportunities for use in this kind of work.
I guess it also, like the dynamics of it, the fact that it was changing so quickly and we were learning and unlearning, and there was a lot of uncertainty, and all of that probably is reflected in the data. And so figuring out those trajectories and how to cope with them, I bet, is invaluable. Can you share any research or case studies that support the efficacy of AI in delivering accurate and empathetic health information?
Yeah, so one of the first noteworthy studies on using large language models for health communication interactions was by Ayers last year, where they showed that individuals preferred large language model powered chatbot generated responses. So they preferred these chatbot responses to physician responses. They thought that the chatbot responses were preferable over physician responses to online medical queries. And that study has now been replicated a couple of other times. Then earlier this year, Google Research trained a model named Amy to have diagnostic conversations with patients. They studied it using patient actors in made-up medical scenarios. And the use of patient actors for diagnostic dilemma challenges is a widely used testing function in medical training. So this is not unheard of to use patient actors in this type of study. And the patient actors had digital interactions with either the large language model or with a real physician. These responses that were created by the language model or by the physician were graded by the patient actors, and they were also graded by specialist trained physicians. And so this Google research paper demonstrated that their large language model outperformed physicians on almost everything that they measured. So they outperformed on diagnostic accuracy, they outperformed on empathy, they outperformed on perceived openness and perceived honesty, and a few other measures. And so I think this is a really important study in this space. Even more recent is a small study that was done in cancer settings, which was published just last month in May, where 200 responses were rated by oncologists, and the evaluators rated these chatbot responses to be better than or higher than physician-generated responses in the categories of empathy and quality and readability. So all of these studies have limitations. Most notably, the limitation is that these interactions are in digital spaces, which is a non-native situation for a physician to work in. So physicians have their training and their expertise in in-person interactions. I had zero training on digital interactions through any of my medical school or residency training or practically, in clinic. So it's important to understand that these studies have limitations when you're saying, oh, the large language model is clearly better than a doctor. Well, this is a doctor performing in a totally non-native situation. But that being said, this trend is very real.
And Gilad, I just want to connect this back to the earlier part of the conversation we've had with you today, which is to say, when we started to think about the role of opinion leaders and then what's common between opinion leaders and social media influencers as opinion leaders of the digital age, and then we started to think about AI as sort of this like next phase of opinion leadership in this new phase of the digital world. This is some of the evidence that kind of informed that thinking, right? Because what we started to see was that in fact, some people prefer these tools in certain environments. And in fact, they are being able to provide empathetic and tailored and personalized information to people. And so if we consider the historical literature and the theoretical foundation, and then how that has been evolved to adapt to a digital world, and now we're in this AI-driven world, this is how all those pieces are hanging together.
Well, I think that findings that AI is nicer than people is definitely a statement on the state of humanity today, but I totally empathize with that, certainly before I've had my first cup of coffee in the morning. From an ethical and privacy perspective, how do you think about the system? We talk a little bit about how to avoid the tool suggesting using non-toxic glue for cheese pizza, for example. As far as safeguarding bias in the data and the ethics of using this, are there any concerns and how do you address them?
Yeah, absolutely. And I think the glue on pizza and eating rocks examples are very helpful in highlighting this need that we have for incorporating ethics into AI product development at every step of the development process. So Amelia and I have talked about this and written about how we think it's important to explore how medical and public health principles, sort of our fundamental principles, should be integrated into AI tool development when it's going to produce or might be possibly producing health information. So these four fundamental principles, non-maleficence, beneficence, autonomy, and justice, these are the principles that guide clinical research, public health, all of these spheres. So as a clinician, if we want to talk for a minute about non-maleficence, if I want to use an innovative and new treatment to help my patients, which I do, I want to use innovative strategies to help my patients, and especially when they offer benefits that didn't exist in the past with other treatment products or modalities. However, it's my duty to ensure first that I do no harm, that I'm aware of and take into account the risks and the downsides, and then make a calculated estimate of that risk and benefit ratio before I implement a new treatment tool on a human being. And so the risk of taking non-maleficence too literally is that you can also create harm through non-action. So you also have to be aware that sometimes doing nothing is actually doing harm, and really balancing what you're doing there. And the same thing should be done for AI product development when it's going to or might produce health information. The intentional avoidance of harm should be at the core of AI product development and deployment. And then another of those fundamental principles that we use in medical ethics is justice. And it means treating all patients equally and fairly. And when it comes to health AI ethical deployment, there may be no area of greater need than in ensuring justice for all users. especially when we think about historically marginalized populations that are disproportionately impacted by false health information, and they're also more likely to be impacted by bias. So at every step of the product development process lies the potential for introducing bias that can worsen these inequities. Technological solutions exist for preventing and reducing bias generated by large language models. So things like doing prompt engineering to have your language model think step by step has been proven to help reduce bias. Avoiding letting your LLM assume a persona has also been shown to help reduce bias generation. And then there's sort of post-in methods like re-ranking and technical modifying loss functions. These are all kind of technical solutions that you can use to reduce bias in a large language model. But there's also a need for just including diverse community perspectives through participatory research to better understand what fair representation even looks like for these people. And that's exactly what we plan to do at NORC.
And Devat, I'll just add that just the importance of that participatory design. We are advocating in this work and in the paper for including community members for whom these AI tools are being developed in the process, right, in the science, to make sure that their perspectives and their opinions are included in the design so that it's created with them and not just for them. And through our Center on Equity research, we really try and embed this kind of approach in the work we do. It is something that I think creates additional challenges as we talk about this new technology, because it does create sort of just challenges in terms of the technology is so new and so it's evolving. It's not quite there yet for us to be able to do this easily, but we are big believers in this idea that we need to start from this place in order to make sure we get there. Because if we just do what's easy, we're never going to actually achieve what really should be achieved, and that runs the risk of further eroding trust.
Yeah, absolutely. And speaking of trust, Rebecca, I brought up a point that I think I've always wondered about, and I'm curious about. I think that in health tech, in particular, there is a big barrier to entry for practitioners to use tools, technology tools, and AI tools in particular, because of trust. You don't know where the information is coming from, what calculations are being done necessarily, and so how, as a practitioner yourself, how do you approach looking and utilizing this tool, given that, and try to overcome this barrier for a practitioner?
So I'll address that question from two different perspectives. One is from the perspective of a clinician, which you're asking me for. When I think about integrating any type of new health tool, whether it's into my own practice with my electronic medical record or whether it's something that I'm recommending for a patient, I'm not going to do that until I know that it's safe, until I know that it's well vetted. I can discuss tests or tools or technology tools with patients and kind of talk to them about the state of the science around it and what we know about it, but I'm not going to actually recommend it until I know that it's safe. So my lens is sort of, from these ethical medical principles, which is you just have to first do no harm. You have to make sure that before you deploy or implement something that it's been safety tested on the population you intend to use it for. I'll also say that from the technology side, I have done quite a bit of consulting for Google, both as an independent contractor and as a vendor. And a couple of years ago, Karen DeSalvo and Michael Howell wrote a paper that meant a lot to me about the importance of implementing clinician members into technology teams for digital product development. So they recognize that, Google and other companies have spent years and in some cases decades working on technology products for healthcare professionals, but didn't include the healthcare professionals in the design or the deployment or the implementation plans of those technology products. And so they failed. And so it's very important to have a clinical team member, to have a health expert involved in every process of the development. And so that paper that they wrote meant a lot to me because it speaks to the importance of my role in what I do with consulting for technology companies and my role here at NORC in helping to develop this AI tool through a clinical lens.
Looking to the future, What dynamics do you think or shifts are necessary for public health and medicine to effectively embrace AI solutions in health communication, given all of the barriers that we discussed?
Eli, that's such a great question. And it's a really, really important one. And it has to do with the future, but I think it actually has to do with like right now and like what needs to happen now. We've talked a lot about on this episode already, this idea of health communication AI, and have focused a lot on the development of this chatbot that Rebecca and I are working on. It is that, but it is also a call for this larger new scientific agenda to really understand on a number of factors, what do these AI tools really mean to people? How do people interact with them? What are the unintended consequences of interacting with these tools? And how do we protect and support people, knowing that AI will be part of our lives into the future? How do we protect people and give them the support that they need to be able to safely and effectively use these tools so that they can benefit from them and so not have so many negative consequences from using them? The example I like to give for this is 20 years ago, social media emerged, and myself included, most of us were very excited. And certainly there have been great benefits of social media, but there also have been a lot of unintended consequences. And we're seeing that now very, very strongly emerge in the spaces of youth and adolescent mental health, body image for young girls, and other related issues, bullying and different types of violence or threats of violence. There is a lot of literature. It is not all on social media. And there is a lot of evidence that show that it is what you go into social media with that can get amplified by participating in those environments. So in some ways, social media helps people find others like them where they may not have those people around them physically in their communities. In other places, of course, people are going into social media and they're experiencing a lot of interactions and content that can be quite damaging to them. It would be great if we could start working now on the research agenda to better understand those kinds of interactions and the risk or the potential for risk that could exist so that we can be building these supports and resources for people along the way. And so we're not trying to then do this and retroactively and address and support people when so much time has already elapsed. And with how quickly technology is moving, we're not talking about another 20 years. We're probably talking about another couple of years before we start to see some of this. Mm-hmm. So it really is about recognizing that this is here. It is part of our lives. It will be increasingly part of our lives. And the best thing that public health and the medical community can do is to figure out ways to embrace this, to have a voice in these early stages, to be at the table, to advocate for certain types of community participation, for certain types of perspectives, theories, approaches that need to be woven into the tech build process in order to make these safe and effective for people of all types, anywhere, anytime.
And then while we are waiting for AI systems that can combat health misinformation, from your work with it, from looking at all the data and from your experience doing this for these past 2 years, can you give us any tips on identifying health misinformation online today?
Yes, the biggest piece of advice that I can give you is to ask your doctor when you aren't sure what to believe. Have a primary care physician and use them as a resource. They care about you and they want to help. Another tip is to check your source. Know if the information that you're reading is from a credible expert or an authoritative health system or resource. And if not, because some people, have, and sometimes with good reason, not trusted authoritative health sources in some cases. And so if it's not coming from an obvious credible expert or an authoritative health system, see if you can find any other credible source that's saying the same thing. So not everyone has time to triangulate the truth and curate their own list of experts that they trust, but I do think that's a reasonable strategy for a person who is not finding what they're looking for from authoritative health sources. Another tip is to consider if the content that's being written is trying to get a highly emotional response from you. So does it use polarizing language? Does it lack the nuance and details that are probably necessary to fully understand this concept? And then lastly, looking for if the information is claiming to be some kind of miracle cure or some kind of easy life hack for what is probably a complicated problem. Because if it sounds too good to be true, it probably is.
So no, don't believe ChatGPT about medical diagnoses, and Twitter for that matter.
I don't know. I may beg to differ there. I think that that OpenAI is doing some strong work around creating the ability to give really accurate information. It's a hard thing to do, though.
Okay, so
they're really working on this.
consider ChatGPT's advice, but double check with your doctor.
Exactly.
There
That's
we
right.
go. Thank you so much for being a guest on the podcast. If people are interested in the study, in this paper, where can they find you and this research online?
So you can actually visit the NORC website. So that's norc.org. And we have a page called Health Communication AI. All of our research, information about the work that we're doing is on that page. And then there's a contact us email and information there. We'd love to hear from people. We want to hear from people who have ideas and who want to work with us. And so please reach out. We'd love to have a conversation.
Well, thanks for joining us today and listening to this episode. Please remember to subscribe, rate, and review our podcast. And if you have any questions you'd like addressed, send them to who'syourdatanow@gmail.com. That's who'syourdatanow, all one word, @gmail.com. Thanks, and see you next time on Who's Your Data?